What's up guys, Dr. James Surratt here. Today I'm going to be sharing the 5 blood tests to absolutely delete fat while on a GLP-1 like Ozempic, Zepbound, semaglutide, tirzepatide. Whether you're already on a GLP-1 or it's something that you're heavily considering and you want to do things right the first time, or you're completely stuck in a plateau right now, the test that I'm about to share with you will literally show you if your body is geared towards burning fat and working with the GLP-1 or swimming upstream against the GLP-1, blocking the results that you could be getting. And when I say results, I'm not talking just about fast weight loss. I'm talking about weight loss that's sustainable long term. This strategy that I'm going to share with you is particularly relevant if you're in alignment with my viewpoint of GLP-1 medications. We want to use the lowest effective dosage that works for you and your body to be able to lose weight safely, comfortably, and most importantly, without any side effects whatsoever. When microdosing or taking the lowest effective dosage, other things can get in the way sometimes and lead you to believe in your mind or your doctor's mind that you need to increase your dosage in order to get a good result. I would heavily disagree with this, and I'm going to show you these tests right now that I believe lead to better outcomes. I'm going to share a patient with you. Her name is Sarah. She's a 45-year-old female. She originally came in and she was struggling with weight loss resistance. Her doctor started her on tirzepatide, 2.5 milligrams. She was not seeing the results that she wanted after about a month. She was exercising, she was working out, lifting 3 times a week. Felt like she was putting in a lot of effort, not seeing results. Came in to see us frustrated. So I'm going to show you what we uncovered here and how we went about getting Sarah a good result. First off, I want to talk about how we check blood sugar, and it's not just a blood sugar I want to look at. I also want to look at fasting insulin and hemoglobin A1C. We want to look at these 3 markers together because this will determine your level of insulin resistance that's present. If insulin resistance is really high, then you're going to meet a lot of weight loss resistance along the way, and this may mean that you do need a little bit higher dosage of GLP-1 throughout your journey in order to get you a good result. So when you hear people talk online about slow responders or non-responders, it just may be that your insulin is higher than the next person's, and so your results are going to vary from person to person. Let me show you what I'm talking about. Sarah's fasting glucose right here is at 95. Now, if you look at this chart, it tells you that it's within a normal range. I actually want to see this down a little closer to 80. But then we pop over to her A1C, it's at 5.7. This is far too high. And at 5.7, this means that there is going to be insulin resistance there, hands down. We just don't know how much yet. Now, I want to see this number down closer to 5 to 5.2 to be ideal, but it just shows you what we're working with so far. Next, we have a fasting insulin. Now, a perfect fasting insulin is at about a 5. Hers is at a 7. So the cool thing about Sarah here is that I consistently see patients that have insulin resistance that are, have fasting insulins 15 to 20. That's much higher and have a higher level of insulin resistance present. That means the control mechanism over your blood sugar has been desensitized to the point where it requires more insulin output from your pancreas to control the sugar that's in your blood. So at a 7, we now know that insulin resistance is not that bad. I can get this patient down below a 5 probably in a month or 2, no problem. What information do we get from this? First of all, this tells us that Sarah is a great candidate for microdosing, and I really don't want to increase her dosage up past where it is or very far past where it is when it comes to her tirzepatide dose. Like I told you, when I first evaluated her, I saw that she was on a starting dosage of tirzepatide, not seeing a result, right? Well, I'm not super excited to increase her dosage, seeing that her insulin levels, fasting insulin levels, are actually pretty good. What we ended up doing with her dosage ultimately was increasing it to every 5 days instead of every 7, leaving her at 2.5 milligrams of tirzepatide, and that worked beautifully in addition with what I'm going to show you next. Second thing to check is going to be a full thyroid panel. Most doctors just check this top value, the TSH. That is not enough to tell you whether your body is operating at an efficient level for your thyroid hormone, specifically for free T3. This is what determines your metabolic rate. More often than not, for a man or a woman, if you are not successful on a GLP-1, you have to evaluate these values. If you are seeing a free T3 below 3 here, and you're in the 2s or like low 2s, that is your metabolic rate being too slow to effectively control your thermodynamics, control your body temperature, control your metabolism, and that will slow down your metabolic rate. and it will fight against your GLP-1 tooth and nail, and a lot of times it will bring weight to a dull roar or just a standstill altogether. Sarah's TSH was a little on the higher end. So we can see that her thyroid, aka her brain, is trying to communicate with her thyroid gland, telling it to produce more thyroid hormone. Her thyroid gland is listening, and it is producing adequate amounts of free T4, inactive hormone, and her body is converting that over to the free and active form of T3 at 3.2, which is a normal range. We're going to leave this alone for the moment because when you see a TSH, we call this subclinical hypothyroidism, where TSH is on the rise. Anything over a 4 is very abnormal. I like to see this in the 1s. When you see this, there's one of two reasons typically. First off, you can see down here that her thyroid antibodies are just fine. They're below detectable amounts. So the autoimmune quality to her problem with her TSH is not existent. The next largest problem is going to be blood sugar and inflammation. One of the two of those can also impact the thyroid gland negatively and cause this reaction with TSH to occur, both of which are happening. We just saw the A1C that's elevated. Next, we'll be taking a look at some different types of inflammation that can cause this exact pattern to occur. Now, before we get to inflammation, I want to talk about something else that can throw off the thyroid, and it's a completely separate marker to check because it can be very responsible for a lot of things that can go wrong with weight loss. Let me show you. So we're going to talk about iron and then iron storage. We have the ferritin, which is the iron storage, and then we have your iron panel. So just looking at Sarah's, I can tell you that yes, her iron might be a little bit on the lower end. This is what she's taking in, her nutritional iron. This could be better. She needed to increase her red meat intake, green leafies, basically intake of iron. I did not put her on an iron supplement, and I'll show you why. Her ferritin's at a 50, which is also a little bit low. I usually, when a ferritin is, let's say in the 50 range, I typically will not put someone on oral iron. I'll typically more focus on the nutritional elements of things that are higher in iron for the body. It is a little bit lower than I want to see it. I want to see it closer to 90. For a woman that is still cycling, this is not a bad number. How do we get it up? How do we improve iron storage? One, we increase iron intake. Number two, we want to work on digestive health. We focused a great deal on digestive health, so ferritin was not much of a problem. Now, why do I bring up ferritin or iron in relation to thyroid? Because iron is a cofactor that is needed for the thyroid to produce thyroid hormone and convert thyroid hormone to its active form. So a lot of times, if you see you have a big thyroid issue, there's no autoimmune component, and you're like, why do I have a thyroid problem? Then you check again, you look at iron and ferritin. If your ferritin's tanked in the red here, let's say like under 20, then you know that your body has a deficiency of iron, and it's likely causing your thyroid to be underperforming as a result. Next thing to test is your free and total testosterone or an entire testosterone panel. I'll show you an example of one right here. So why is testosterone relevant for you? Because if your testosterone is too low, it's very difficult to gain muscle, and your body is going to have a propensity to store fat more often. The other problem with low testosterone is it can create a lot of fatigue and poor recovery because free testosterone's job is to go into each and every cell and help regenerate that cell. So with a cellular energetics in mind and cellular power in mind, if you have low testosterone, your ability to recover at any given point after a workout, after an injury, is going to be very low. This patient, for her age, in her 40s, I would say that her testosterone is in the low normal range. We first look at total testosterone. Keep in mind that the top of the range is about 50, and I like to see my patients in the 40s typically, if not all the way towards the top. Now, this doesn't tell the whole tale. We look at this, it looks like it's a little low. Then we come over to the free testosterone. That is what's actually bioavailable, ready to be used for a cell, and this is how I want to gear treatment. Her free testosterone, when you look at this scale, it looks like it's kind of high. I would say that her testosterone is middle of the road. No intervention is needed here. But let's say she was like 1.5 or below, then we would want to consider some sort of intervention, whether that is an herb that's going to help promote the production or conversion of testosterone or testosterone therapy itself. I do consider testosterone therapy frequently in women over 40, especially when you start to see this free testosterone under a 1. That's when your body's really screaming and begging for more testosterone and it's not there, and then it's almost always going to play a role in somebody's lack of weight loss or inability to lose weight. Remember, this applies for both men and women. I prescribe just as much, if not more, testosterone in my practice to women as I do for men because I believe it is a fundamental hormone of longevity. And last but not least, we have our inflammatory markers. First, let's look at a ESR or a erythrocyte sedimentation rate. Right here tends to show people their head to toe levels of inflammation. I like to look at it as extracellular inflammation. She's at a 33, so this is basically off the charts high. I typically see this high in people that are just struggling with daily pain, leaky gut, or other autoimmune conditions that typically go hand in hand. You can see right above this, another inflammatory marker that we check is also a autoimmune marker, rheumatoid factor. So we checked her for rheumatoid arthritis. This patient, Sarah, she was struggling with a lot of pain. And you can see here that she did get flagged positive. Now, luckily, we were able to get this rheumatoid factor down over time and get her out of harm's way for rheumatoid arthritis down to about a 10. Sedimentation rate, this is definitely relatively severe. Keep in mind that anything over a 6 is relatively high inflammation, and we're trying to get people down to a 2. For Sarah, we really hit hard on nutrition, digestive health, making sure that we removed inflammatory components for her diet. We put her on a treatment protocol for leaky gut, along with the GLP-1 therapy, and this number came down significantly. The last marker to check for inflammation is called an HSCRP, or a highly sensitive or cardiac CRP. This looks at more vascular inflammation. I want to see this below a 1 in each and every patient. It typically mirrors the sedimentation rate, but in this case, this patient had less vascular inflammation to start off with, so this was less of an area of focus. Those are the 5 tests that I would recommend that you get your doctor to check before starting a GLP-1, or if you're on a GLP-1 and you're wanting to get the best results possible, definitely check these things. And the cool thing is that once you get your results, you can track them over time to track your success and your progress. Like and follow, comment, send it to a friend if you feel like this would be valuable for them. Otherwise, God bless, and I will see you next week. Take care.